All right. So today we're not talking about college careers, but we are talking about relationships. And so yeah, thank you. We're going to talk about the idea of what a person-centered home is, and also ideas for making a person-centered home for persons with developmental disabilities. And we unfortunately have no financial interests or related to the content of this activity. And this information is based on evidence that is accepted within the profession. So person-centered home, the concept of medical home was first introduced by the American Academy of Pediatrics back in 1967. So it's not a new concept, but I still find that depending on where you are and what discipline you are, you may or may not have heard of medical home, and that patients often have no idea what we're talking about. So how many of you are familiar with the concept of medical home? And can you use your chat box, or I don't know?
Yeah, thumbs up.
Thumbs up will work.
Excellent.
Okay. So there are supposed to be 5 functions and attributes of the patient-centered, person-centered medical home. One is comprehensive care. What we're going to focus more on today is patient-centered. Certainly coordinated care is something that is a struggle, I think, for us all often. Accessible service, and then quality and safety. The primary medical care has a relationship-based orientation toward the whole person, and it requires partnering with patients and their families, and requires understanding and respecting each person's unique needs and culture and values and preferences, which can sometimes be challenging. So our objectives. Yep, you're doing good. Our objectives today are, we're going to discuss some barriers for persons who have intellectual and developmental disabilities from transitioning to pediatric to adult care. I'm going to talk a little bit about shared decision making and some tools that support shared decision making. And then we're going to have show and tell. There are some really cool resources that I would like to show you for caring for persons with intellectual and developmental disability in primary care. I stole these slides. Oh, next slide. Did I do this? Okay, yeah. I stole these slides. I asked Jean Hall. Jean Hall is the director of the Institute for Health and Disability at Policy Studies at KU Lawrence, and she had given a brown bag presentation. I don't know if any of you had the opportunity to see that. She is the principal investigator on a grant from the CDC that funds their project to promote health and quality of life in Kansans with disabilities by increasing access to programs and services that promote healthy living. And she showed us, I think, that in the United States and in Kansas, they're very similar, our state to the national statistics. There are really very large disparities in both physical and mental health. So you ask people how they rate their health, self-rate their health. Americans with disabilities really have a much higher likelihood of saying that they're only fair or poor. They have many more days of being physically or mentally unhealthy. And so this is a significant disparity. And disability by itself doesn't mean you have to have poor health, but right now we have that problem. Thank you. There is also persons with developmental disability are at higher risk for a variety of diseases, some of which are heavily influenced by lifestyle, environment, and access to services, including stroke, heart attack, high cholesterol, hypertension, asthma, diabetes, depression, some of them related to the medications we use for managing behaviors, for example, in persons with developmental disabilities. Again, a lot of disparity there. And there are a number of barriers on the webinar, which I think was archived somewhere. Dot Neri is an associate professor at Lawrence too, and she has done a lot of work on making homes as well as health homes more accessible for people who have physical barriers. And she told some stories of people who had disability who encountered barriers that unfortunately aren't rare. She talked about the patient who asked, why did the doctor order this test if he can't get me up on the table because I can't actually have the test? She talked about the mammogram technician who was really very not supportive of an individual who really had trouble getting into the machine because of all the machinations. And then there's a lot of sort of just system problems. So a person who had intellectual disability and was in a wheelchair and had to have carpal tunnel surgery, but insurance wouldn't pay for the overnight stay or the transport, so led to the not getting the wheelchair. So there are environmental barriers. So there's lack of facilities, including our facility, that wouldn't always be accessible for what we need. We're going to talk much more about lack of knowledge and where the teaching is about developmental disability, and certainly lack of financial resources. So there also is the belief that people with developmental disabilities can't be healthy, and they really can be healthy. So we really need to work to having them healthy. So, and the disability rights movement has really started in the 1960s, encouraged by the civil rights movement, and it has sort of changed the perspective from a medical model, which is there's something wrong and you need to fix it, to there's something wrong with the environment and you really need to accommodate. The Americans with Disabilities Act became law in 1990 and prohibits discrimination against individuals with developmental disabilities or disabilities in general in public life, including not only jobs, schools, transportations, but also healthcare. So it seeks to level the playing field and has united disability constituencies to really address a common concern. And that is fortunately also beginning to happen more in the healthcare field. And we're going to show you some of the things that are going on with that. I think I just said this, but so what makes somebody disabled isn't their medical condition, but attitudes and structures of society. We need to remove the barriers, and some of the barriers are not just the health and physical activity barriers, but also lower income, education levels, and employment. So our second objective after talking about the barriers is to talk about how to talk to individuals with and how to do decisions with persons and their families with intellectual and developmental disabilities. And I think that many of us, including myself, we came up in medical school with sort of paternalism in medicine, and the doctor did it, the doctor said it, the doctor was right about it, and that is fortunately changing. And so shared decision making is the idea that you really have every party involved. There's a process. Clinicians and patients work together to select test treatments, management, support packages, and based on clinical evidence and the patient preferences. So if you look at this diagram, you at the far end of the right, it's physician driven and decided without the patient really having much input. And at the other end, it's you leave the person who has the illness sort of alone without evidence base to support them. And you really need to have good conversation to end up with decisions that are shared and agreeable to everyone. The process balances risks and expected outcomes. This is particularly important when there is not an absolutely clear thing to do, which is the art of medicine and much of the time. So when we talk about making decisions about what should be done, it's particularly important when there really is some risk-benefit ratios that you have to negotiate. There are really some barriers to shared decision-making for persons with intellectual and developmental disability. Knowledge deficit is a big one. There is very little, if any, training on developmental disability in medical school. There is very limited training on developmental disability in pediatric residencies and probably family medicine residencies and internal medicine residencies, which is a major issue.
Or surgical subspecialties.
Surgical subspecialties.
Across the board.
So there are also constraints in the health system that I wish I could say we're getting better, but I'm not sure that they really are. There's limited time for consultation. Visits tend to be short. Some providers really have 15-minute visits. For a well child check, that's really hard for, well, adult check. And when you have a person with intellectual disability, it takes more time. And doing that is sometimes not rewarded very well by the system. Continuity of care is a problem. A lot of people's insurance changes all the time, and you have to keep reintroducing your problem and yourself to the system. Reimbursement issues are, again, a major issue and somewhat tied to the time for consultation, but there are other reimbursement issues too for needed, like wheelchairs and all kinds of other things as well. And then inadequate environmental conditions and our 50-year-old building, 60-year-old building, I don't know. Many buildings really have a lack of environmental accommodations for people who really need them. And that's not only for physical health, but also probably for some mental health issues as well. There's power imbalance in a relationship. This is true, I think, in part, and has led to sort of the physician, I am the physician and whatever, but is probably even more of a power issue with persons who have intellectual and developmental disabilities, consent issues, also difficulties with figuring out in the family who are you working with and who has say. Language barriers between patients, families, and clinicians. There are, again, this is in many areas, there isn't really great evidence for some of the things that we have to think about. And there are some facilitators. Again, the concept of person-centered medical home is a motivation, and setting up a system in your office to think about these processes. There's at least talk of medical home, even though right now I don't think it's being funded adequately. I'm hoping in the future that changes. At least it's in the it's certainly in the conversation in all primary care that you need a person-centered medical home that fulfills all those functions. The Association of University Centers on Disabilities, I don't know how many of you know of what that is. We are part of that. It is a national organization that funds a variety of different programs underneath it throughout the United States. At our center, we have a grant for leadership education and neurodevelopmental disabilities, and that is one thing that they fund. They also fund the University Centers on Excellence in Developmental Disabilities, so KU Lawrence has funding from that, and they fund the Intellectual and Developmental Disability Research Centers. KU has all three of those programs under AUCD, and AUCD is a huge advocacy organization that has really tried to pull everybody together. And recently, it's not just been on pulling everybody together for community supports and for training, it's also pulling everybody together for better health care. So there's 20% of adults in the US have a disability, 1 in 6 have developmental disability. There is currently no training standard for developmental disability in the United States. And the AUCD has been working with partners. It's called the Health is for Everyone Action Team, because they pushed to have the AMA resolution to include education about the unique needs of persons with developmental disabilities at all levels, undergraduate, graduate, and continuing medical education for physicians. And that was an AMA, American Medical Association Academy resolution that did pass. So there is now considerable work on really getting curriculum introduced at all levels of medical education, and AUCD is helping to organize that. So I'm going to turn this over to the person who actually does primary care. There are some resources that can help. And we're going to do some show and tell. So.
Yeah. All right. So yeah, all what Kathy has just described to you sounds like, okay, there's barriers I need to overcome. There's systems issues I need to overcome. How do I do all that to provide care for my patient who may have intellectual and developmental disabilities? So there is help out there. So we're not just going to leave you hanging. So we wanted to briefly talk about the Canadian consensus guidelines that were recently updated in 2018. So Canada has guidelines. To my knowledge, I don't think the US really does, but our friends up north have taken the time to do this. And passion for me because, well, these guys are also family medicine docs, so they come from the same wheelhouse that I do. But they have looked at and reviewed literature and come up with consensus guidelines on a variety of different things and different items on what you should be doing in standard of care and the evidence, whether it's A, B, C, or D, on providing care for these patients. I don't know if anybody's familiar with these that's on camera, yay or nay. But it's a long document, but it's got a lot of good information. The one thing I would say too is it also talks about changing terms and really focusing more on the person-centered care and focusing on the person. And it changed terms instead of like informed consent for procedures, but it's looking at capacity for decision making. And then also there was one other thing I picked out that rather than describing disruptive behaviors or something like that, but saying there are behaviors that challenge the individual that we'd be talking about. And so that's using language that's more person-centered, which I think is important if we're trying to strive towards this person-centered medical home and really putting the patient first. And I think, I'm not going to read the slide to you, but all that to say, this 2018 guidelines then helped build the intellectual developmental disability toolkit that we're about to show you and I'm going to walk through, because this toolkit right here is going to have a lot of just good information, and hopefully the internet cooperates with us. Is anybody familiar with this? Nope, that's a no. Should I just be patient? Yay. Do I have to share?
Yes.
So how do I do that? Hold on a second. We'll stop sharing the slide. Oh, okay. All right, so here's the website. And actually it's really easy to use, and I didn't know about this till Kathy showed it to me, but I think it's got great potential for primary care providers when you're trying to create your person-centered medical home. And I don't know about anybody else, but for me as a primary care doctor, it can be a little overwhelming when you think about someone in the pediatric world who has intellectual and developmental disabilities and all the adaptive things we have to think about while trying to transition them to the adult world, which is a little bit different. Things are more siloed in the adult world. So this is, I think, a great resource to help a clinic provide the best care that we can for individuals. So the first thing I wanted to show you is under this tab, maybe. Okay. So under the general issues tab, there is, how much time do we have?
We have quite a bit.
We have quite a bit of time. Okay. So I was going to go to the adaptive, I've kind of ranked them in order of importance. Okay, so I thought this was an interesting adaptive functioning communication associated with different levels of intellectual and developmental disabilities, IDD. So what this does is if you have a patient coming in or an individual and you know that there is concern for developmental delay or disability, you can, while the IQ may not be the perfect thing, but it's a way to identify their intellectual functioning and then compare to what their adaptive functioning might be. And that the adaptive functioning are the skills that someone might have to help them handle common things that happen in everyday life. So if someone's IQ is 55 to 70, they might need some income support. They might be able to make their own decisions depending on the situation. Then also give suggestions on how to communicate maybe more effectively with this individual. And then as we scroll down to like severe and profound, it sort of ranks out, they might need more 24-hour supervision, can't make their own decisions. They might be nonverbal. So how do you communicate with that person? So I thought this was an interesting thing to look at if you're trying to figure out how you're going to best communicate with an individual and be successful in that encounter so that they come back, they feel they feel trust in your clinic. So that is that one. And then the other thing that I was going to show on here next is one thing that Kathy mentioned is capacity and who's informed, who does informed consent. And when we get into the adult world, well, people 18 and over sign their own consent forms, you know, so it's not mom and dad anymore. And so you need to decide who's that going to be and what it to help you make decisions. What I thought was interesting here is there is, no, where is it? A actual informed, sorry, the computer's not working with me here. A checklist that's on the website to help you determine if someone may or may not have the capacity to make a decision. And it's just yes or no questions or unsures. Like, does the patient understand that you are offering an intervention for a health problem? Does the patient understand the nature of the investigation or treatment? Does they understand alternative treatments? And then at the very bottom, it says, you know, capable, not capable, unsure. And then even what to do if you're unsure. So if you've done some of this, you're like, gosh, I'm still not convinced they can make the decision to get, I don't know, that
surgery,
that gallbladder out, or even something as benign as, I don't know, vaccines are pretty benign, but you can talk to your facilities ethics committee if you have such a one, or even just talking to a second physician who maybe isn't involved in that patient's care to help determine if that person has the capacity. So it's just it's a nice form that exists out there to help guide providers in determining capacity. The other thing I thought was interesting under this is the communicating effectively tab. So there is suggestions on, and I think this stuff kind of applies to just life in general, personally. Really, it's not rocket science by any means. And if you just make it part of your normal vocabulary, you're going to get further. But how do you establish rapport? You speak directly with the patient. You talk to them. You don't talk to the adult in the room. You ask the patient questions. Do you want your support worker or caregiver here? Give them a little bit of autonomy depending on the situation. You know, trying to figure out how the patient communicates. Avoiding jargon, using plain language, using concrete sentences. So rather than, you know, show me X, tell me this. Just, like I said, sort of common sense stuff. But if you are just wanting to refresh yourself before you go in a room, what's the best way for me to communicate with someone? This is a helpful thing.
I think people who have developmental disability adults often, you know, it's and I recognize sometimes I do this. I talk to the caregiver and not talking to the patient enough. And people in wheelchairs note that all the time. People talk above them to people who, instead of looking really and talking directly.
And like this applies too for people who don't speak English as their primary language. I mean, we tend to maybe sometimes talk to the interpreter, talk to the family member who speaks English, but no, you still need to refer to them as, you know, what do you want, not what do they want, sort of thing. So the other thing I was going to show, if you are wanting to make sure that your office is supportive of an individual with intellectual and developmental disabilities, there are some office organizational tips on here. You know, how to have your office staff ask patients if they have a need. So there is just, I'm not going to read all this stuff, but good information for if you are considering, you know, how can I improve my care for patients with IDD, and then follow-up visits and things like that. And then also about if there's exams or further work that's needed, how to go about doing that. And then the other thing I think that I wanted to point out here too, and I'm also the program director for a family medicine residency, so these are little tidbits I've taken away for myself, and we've come across this in our own primary care clinic. When you're referring someone, it's important to relay that information that someone might have a need rather than not, so that they can also prepare their office staff and provide the best care possible, rather than sort of leaving it off the chart or not including that in the referral. Just you close the loop, and again, that person, the party on the other end, can provide the best care that they can.
And it could be, you could say, you know, what are their needs, or what's going to make them more successful, as opposed to like, here's what is wrong, or here's their deficits. You can, you know, oh, if you had this in place and this in place, that might help it go better.
Or if you want them, if you're trying to have a smoother conversation at the get-go. They like X or have this available, or
Right.
Yeah. So then there is this physical health issues. So let's see, I was going to show you. The other thing that's on here is the cumulative patient profile, and I felt this was helpful. So one thing that I have patients with intellectual developmental disability in my patient panel, but the other thing I've started, and actually I see Moya's on here, Moya Peterson, but we're doing a adult Turner syndrome transition clinic, and we have a transition form that those patients complete so that we can get all their medical history, what hormones they were on, all that sort of stuff, so that we can have it all in one piece of paper that we can then review with them in clinic and then keep it in the chart. And this is something very similar to that. And I think it's really helpful that if you wanted to use this form, you absolutely can, but it could be mailed to the patient. It could just be given to them at their front desk and they check in, but it's got all their stuff, like why etiology of developmental delay, their genetic assessment if they've had one, psychologic assessment, what's their living situation, level of adaptive functioning, decision-making capacity, and who's their substitute decision maker, all things that would be nice to know as a primary care provider. If this person was coming to my office, I have all this in my hand, it might alleviate some of the angst or anxiety I have about taking care of that individual. Things like special needs or communication. So if I could walk in knowing that someone really communicates well with pictures, then gosh, I can start my visit off a lot easier than trying to have a conversation that's probably going to get us nowhere. And then meds and problem lists. The rest of it's a pretty standard form. Okay. So then they also have these female male preventive care checklists. I didn't really think those were that helpful, actually. So I'm not going to show them to you. They didn't stand out to me. But one thing I thought that, and I've run across this again in my own clinic and then also working with the residents, is if there is a concern by a caregiver that there is new behaviors or changing in behaviors, well, gosh, what's the culprit? Where do we start? And this is Dr. Cheatham, I guess, made this checklist, and he's also another family doc. I think he's from Tennessee. But looking at drugs, are they constipated? Something as simple as constipation can make someone
frequently
unhappy, rightly so, right? GERD, seizures, are they aspirating? Is there a syndrome that's involved? Is the behavior different than normal? Are they having any pain? Because we wouldn't really know, but how would we know? Sometimes the caregivers know that. Well, when so-and-so's big toe hurts, they tend to hit or something like that. I don't know, that's a weird example, but.
We had one though recently that was just getting the right pair of shoes for the child really did change his behavior.
Yeah, right. I see that with my diabetics. They trim their toenails, everything feels better. And then maybe sleep is an issue, or they're not eating well, or even dental problems is a huge thing. And I think this doesn't just sit in the realm of IDD, but trying to get those teeth cleaned and get those bad or cavities out can really improve someone's nutrition, how they feel in general. And then lastly, is there a psychiatric disorder? And one thing we'll talk about, I'll show here in a little bit, but for psychiatric disorders, 30 to 35% of the time, someone with a intellectual developmental disability might have an underlying psychiatric disorder. But what that means alternatively is that the majority of the time it's not that. And I think as primary care providers, sometimes it's hard to tease that out, or we want to just say it's the developmental delay and it's not an underlying psychiatric disorder. So I think for me personally, that's a difficult thing to tease out, but something that we need to be considering in the top of our heads. Okay, so the other thing I was going to show you, I thought these health watch tables are pretty cool. So I didn't really like the preventive care checklists, but these are cool because they went through and developed essentially checklists or tables, things to look for individual diagnoses, and they chose these, whether it's 6 based on prevalence in the United States. But I think also as a primary care provider, anything I can find to sort of help guide me, is going to alleviate that angst and that anxiety I might have about seeing an individual with, for example, autism, depending on the severity of their autism. So what it goes through is essentially it's systems based, and it tells you for children and for adults what you should be looking for, and then maybe even how often to do it, which is great too. Again, trying to alleviate some of the I don't know what I'm supposed to be doing anything different. You know, for children with autism or even adults, it's important to ask about any specialized diets they may or may not be on. And that food allergies are common. It talks about fertility, then some seizures and tic disorders. And then the other thing is, as I had mentioned too, so the behavioral and the mental health component, I think, is the biggest source of we don't know what we're doing when it comes to primary care providers and needing more guidance. And so this is one way that we can look for help in a form that's a little bit of evidence-based, at least, behind it. So I'm not going to scroll through all that. Like so there's one for Down syndrome as well, and it talks about, for them, cardiovascular disease stuff, which might come up as an adult. So if I have someone with Down syndrome transitioning in my clinic, they might have mitral valve prolapse that gets acquired as an adult, something I need to look for. And then how often do I need to send them somewhere? Do they need to see a cardiologist really? What's that about? They're at high risk for sleep apnea. The other thing is that adults with Down syndrome do have a risk of celiac disease, 7%, so screening for that. They're also at risk for testicular cancer. So this is just really helpful, I think, if you know someone's coming in and they have one of these conditions, that you can review that coming in, or even take it in with you and make sure you've checked your list and make sure that you've hit all the things that are important, so you can provide the full care that someone needs. Because as we discussed, with these individuals deserve optimal care too, and should get the best that we can provide them. So this one is what I click on, Fragile X, I think. Mm-hmm. Yeah, which Kathy's
You're going to start that Fragile X clinic for me? Yeah. Fragile X is such an interesting condition because people who have premutation are also at risk for a variety of different diseases, adult diseases that need to be recognized. And so the families of Fragile X individuals are very interested in getting help with adult health care.
Yep.
So we're working on that.
Mm-hmm. What do we need to be looking for? Right. So, so I thought, again, those health watch tables, I think those are really interesting. Oh, and then there's a section on behavioral and mental health. So as I mentioned, there's 30 to 35% of the time there may be an underlying psychiatric disorder. And a lot of times it's easier to say, oh, well, that's just part of their developmental delay or part of their syndrome. That seems easier, I guess, than trying to uncover a psychiatric disorder, but we need to be considering those things. So this also has a lot of different tools on it. I will say, I was hoping for like the golden nugget, use this medication if this.
I'm still hoping for that too.
Right? That doesn't exist. The only thing it does say is for autism, risperidone and
aripiprazole,
Abilify.
but should not be first line drugs because they have many side effects.
Right, right. And that's the other thing to point out too, when it comes to, wanting to treat or identify behaviors, you should really try to figure out what is the underlying cause first. Because if we start tossing meds at people, well, gosh, there's side effects from those medications that can make things worse. So really need to be cognizant of that. And I think thinking about the environment's a big thing. I can think of one of my guys who has a rare congenital anomaly, and he recently moved to a small home where there's 2 other adult males. And he had been doing fine. He has a little outburst here and there, but every evening from like 4:30 to 6:30, he's more difficult to control. He has tantrums that last a while, and the caregivers came in asking for me to treat that, and I was like, well, it's only for a couple hours. I'm not going to slam him with a medication to gork him for, so really it came down to, we had a lot of structure at his day center, and then there wasn't much structure from 4:30 to 6:30 or whatever before dinner. And so he needs that structure. And so we brainstormed together, how can we give him structure or something to do that he needs to do so that he can just do that. And so hopefully that worked. I'll see him in follow-up soon, but, and so I was like, giving him medication isn't going to fix that 2-hour window. So things to consider. Anyway, what else? So were you gonna say something?
That's a great point.
Yes.
Is families are heading into the summer and the change in structure. So thank you for mentioning that.
Yes.
I like the ABC chart too, that what happened before, what was the behavior, what happened afterwards, which is key to.
I was trying, so this one's good too, to try and figure out, what happened before, what was the behavior, and what was the outcome of that. The other thing, I saw something that was almost like an asthma action plan, which I thought was great for primary care providers. Which one is it? It's the crisis management form, I think. Okay, let me give you the example. Oh, where's the example one? Sorry, guys. Risk assessment tool.
They look like there's 2 crises, prevention and crises
It's this one.
planning. Okay.
They had an example one. I can't find it. So this is a nice form. Like I said, I consider almost like an asthma action plan. So you can think about what is the stage of patient behavior, are they normal, and then what kind of responses do the caregivers need to give in order to maintain those positive responses? And then what are the early signs that there might be a trigger happening, or what is that trigger and how can you prevent that trigger? And that's going to be very individualized to everybody's needs. But if it's written down, so if there's a change in caregiver because someone's sick that day, so it's not Mrs. Smith that's usually there, what can we do to help keep that structure in place? Or even for like my own office visit staff or clinic staff, there's some patients we know that are more aggressive at times, like I've been swung at. So knowing what is the trigger going to be, well, it's me looking in his ears. So how can we sort of mitigate that? And if we can have my nursing on board with that and the check-in staff, so that when it comes time for the actual exam part, he's calm, then that's helpful. So I think, again, this having an action plan so you can prepare and identify and respond in a manner that's, again, going to be person-centered so that you get the best outcome for everybody. And they still return for care. Because what you don't want to do is have them have such a bad experience everywhere they go that then they don't get care. Mm-hmm. And then all those disability, the other chronic disparities, the health disparities, thank you. And all those other things can just get worse because they're not getting the care that they deserve. Oh, here's the example. So at the bottom. Normal calm behavior is talks well about work, people, follows routine. So identifying early signs, they start complaining about work or coworkers, says that they shouldn't be able to do that, or they didn't follow the rules. So what do? You take Jack to a quiet room, talk with him about what is wrong, ask him about a solution. If behavior escalates, so he starts swearing about people or situations in a loud voice, ask him to sit down, sit with him, ask to help him discuss or read the solution he wrote earlier. Have him engage in relaxation techniques, works for this particular example. And then if it continues to escalate, so he starts throwing objects at the walls or floor, then it says keep distance. So put something between you and Jack, make sure you have an exit. Say, stop, Jack, time to calm down, breathe with me. So still doing relaxation techniques, but from a safe distance. You can remove or tell others to leave. And then if you need to, call 911. And then what to do afterwards, right? So I think we're recognizing this all over medicine, at least, even like if there's a code, we do the debriefing. So if this is a crisis, if there's an acute crisis event for a behavior, then what's the post-crisis resolution? So what will Jack do? He's going to go back to his own room. He's going to talk quietly. And then he's going to ask if he can talk about what happened. And then once he's calmed, you talk with for a few minutes about how to re-engage in his routine as soon as possible. So anyway, I thought this was great. I'm thinking of how I can use this for some of my patients.
It would be nice to get some of this into the electronic medical record.
Yeah, wouldn't it be nice to get in some, to EMRs and stuff, right?
Okay, you're right. That's not going to happen right away.
No. Not right away. The other thing that's on there is the psychiatric symptoms and behavior checklist, and this recommends that either the caregiver or the provider can do it, and you can score things, and it really helps. It looks to me more like a caregiver, or I'm sorry, a provider form to fill out, because you're probably going to have to ask clarifying questions. But it can help you lump where some of the behaviors are. Are they anxiety related, or is it mood related? Is it really a psychotic related thing? Is it a movement thing? Is it more of an attention issue, or are we really worried about dementia coming in here, or is it something else? So it maybe helps clump those things so you can then identify, well, how am I going to treat that based off whether it's anxiety or is it a depression thing? Yeah, I looked at this. Again, there was no golden nugget about which medications to use. But the psychotropic medication, this checklist can be helpful to see if, have they been on things before? What have they used? And again, it's just good reminders for providers to go through and get as much information as you can about this individual so that you can make the best decision moving forward in their care. So, okay. I think I'm ready to go back to the PowerPoint.
I think that's about it.
And Nicole, do we have any questions in the chat?
Someone just said that for adults with Down syndrome, a change may indicate a celiac disorder.
Was that Moya? So there was a comment about behavior change in someone with Down syndrome, maybe from celiac disease. Is that correct?
Yeah, someone just shared.
Yeah, so it may be a semi-easily treatable medical issue that just needs to be addressed rather than re-changing the entire environment or starting new medication.
I think we're on the last couple, the last slide, which I think is just referencing resources.
Is it shared?
I don't know.
Share it.
Yes, it is.
Brown. Okay. So we walked through each of those sections with the IDD toolkit, and then we got our references. And that's it. And we'll take any other, if there's any questions or anything.